Hello everyone, welcome back to Hot Seat Season 3. I'm Omid Moghaddas joining you from Tehran, and once again I'm so happy to share this educational platform with all of you from around the world. And you know, as always, when I start each session, I always say that, we try to cover many aspects in implant dentistry in the field of perio, prosto, ortho, and how to be able to manage a case properly. And we went through all clinical scenarios and different techniques, different concepts, paying enough attention to the biology and how it can affect the outcome of the treatment. But something that we always need to remember and keep in mind is that as a dentist, sometimes we cannot do everything as a person. We should have a teamwork. Some of us are general practitioners. Some of us have multi-specialties and they can manage some cases, in one office, or sometimes they have colleagues in one office. But the point is that we need to know exactly the details about the multidisciplinary approaches and how to communicate with our team to end up in a beautiful case management and make it as much as possible stable for long-term for our patients. And today I have a very special guest and a dear friend. Dr. Khalid Alhamdaan is here with me, joining me from Riyadh. Hello, Khalid, and welcome to Hot Seat, my friend.
Hi. My pleasure. Thank you.
So happy that you...
Thank you for the invitation. Happy to see you.
Thank you so much. And today, as I talked about multidisciplinary approaches, we will cover beautiful case management involving many aspects in dentistry like ortho, endo, prosto, perio. So I think it will be a great combination for having a good conclusion of what we have learned over the past sessions and how we can apply it to the clinical practice. And to see the case presentation, it really helps us to get the point properly. So I'm so happy that Khalid accepted the invitation and prepared a beautiful case for us during this session. And before we go to the presentation, I would like to have his CV for all of you as our tradition. And then we will start the presentation. And for sure, as always, we will have a great discussion on the topic after the presentation. Dr. Khalid Alhamdaan, he's a bachelor degree of dentistry from King Saud University College of Dentistry, Riyadh in Saudi Arabia. He is a Master of Science and Advanced Specialty Education Program in Periodontics from University of Michigan School of Dentistry, Ann Arbor in United States. Fellowship in Implantology from the Mish Implant International Institute and Diplomate of American Board of Periodontology. He is currently Associate Professor of Periodontics at the College of Dentistry, King Saud University, and Chairman Students Guidance Unit. So Khalid, we are ready for your amazing presentation and really looking forward for our discussion at the end. You can share your screen
now. Thank you again for your invitation. It was a pleasure to be around, and I'm following the season since the first season, and it looks amazing. I learned a lot, and I keep watching it. Thank you for the whole work done for the during the COVID era. It was like amazing to learn from expertise, and your discussion was bringing fruits for the presentation. I will just share my screen now, please.
Sure.
Let me just bring it back here. Yes, bismillah. So my case today will involve multidisciplinary case presentations and how to look from one case to different perspectives, not only from your side, but also how to share your knowledge and your expertise with others. I received this case back in 2005. I came from the state in 2002, so it was maybe 2.5 years when I saw the case. It was referred from the general dentist clinic. They said patient does want to have an implant for the whole teeth, just she want to remove them. And I said, wait, you want to extract all these teeth and just replace them with implant? It doesn't make sense for me. So she came in 2005. She's 28 years old female, complaining of unpleasant aesthetics. As I said, she was referred for implant in upper lower jaws. Medical history revealed nothing abnormal. So just by digging into the case, I noticed she has like some depression. She went through some psychological status. She neglected her mouth for almost like 5 years. She's not going to any dentist. She's just like staying home. And although she's highly educated, she's an English teacher. So just by looking to the mouth, you could show the negligence that she had. Uh, Multiple case illustrations. Uh, she said, "Just take my teeth out and give me an implant. I don't want to have any teeth in my mouth." I said, "Why?" She said, "I don't want to take care of them. The implant will last longer. They are metal. They don't get decayed. I just want to have nothing than that." And I, I, I start to think the implant will be the real replacement for all these teeth, the natural teeth that she has. There are some couple of teeth that are good to be replaced by restorations, by crowns or veneers to provide a more pleasant aesthetics. This is her bite. The right side and the left side, you could see the collapse and the eruption of the teeth, and a lot of caries teeth are going down. So this is her as usual, always we recommend to take a primary alginate impression. You learn a lot from the alginate impressions. You could see, so eruptions. Imagine if you place an implant in this area, how can you replace it? If you place an implant in this area, it's impossible to replace just by putting implant and a crown. So from that time, I think I wrote an article to the editorial board in Saudi dental journal, about multidisciplinary, how to bring a lot of specialty in one case. So this is their OBG. You could see a lot of caries restorations, caries and multiple restorations in some areas, preapical lesions, awful eruptions, and badly broken teeth. General view of the preapical and the bite wings. This case was like messed up for a lot of times. I think psychological impact also has an effect on this case. So for us as a dentist, we look for the patient not only as just fill and drill and fill, but also we have to look for psychology of the patient, because we influence the patient's psychology and we could change their life, not only but just by filling or drilling. Also, we have to communicate with them. We have to share our knowledge, our expertise. If not, we could also communicate with the psychological treatment. So we could see she's highly educated, although she neglected the oral hygiene. That's why she got with all these caries teeth. She said, "I want an implant." I said, "No, stop. I have an idea." So just let's make the list so we know where to start, where to begin. She has caries, she has gingivitis, preapical lesions, spacing between the teeth, vertical dimension collapse, and super eruption of posterior teeth, missing teeth, horizontal ridge defect, and bruxism. So this is all our list of the problems that I think if you look to all these problems, one dentist cannot do all these jobs. We have to look for something called multidisciplinary, which is combining or involving several academic disciplines or professional specializations in an approach to a topic or problem. So we have a problem here. We have patients that have psychological problem. She has missing teeth, collapse, spacing, bruxism. So I think we need not only one specialty. So in dentistry, it's referred to the dental treatment that uses more than one type of dental tactic, which is not only perio, not only endo, not only resto, not only ortho. So it has to have more than one specialty in that case. This type of multi-level care occurs when there is a complex cases, as we're gonna see later, that need to be treated in many steps. Often we come across this type of situation when dental care has been put off or ignored for many years. So it fit our case as per se. The key is to build a team of like-minded, dedicated professionals who share a common goal of providing optimal oral health to the patients. So by looking to the factors that impact the restorative or prostho treatment, it includes aesthetics, function, and we tend sometimes to ignore health. So most of dentists, maybe general dentists, they tend to focus on aesthetics and function, but they usually tend to ignore the predentium, which is the pink aesthetics as per se. So dental health is a prerequisite for successful comprehensive dentistry. You cannot obtain a comprehensive dentistry without looking for the predentium, because it is the foundation. So in order to achieve a long-term therapeutic targets of comfort, good function, predictability of the treatment, longevity of the treatment, and easiness of the restorations and maintenance care, which is the key is not only to see the case in 1 year, but following years, 5 years, 10 years, 15 years. So active gingival and parental disease must be eliminated before starting restorative, implant dentistry, orthodontics. Any treatment should be preceded by parental disease control. Why? To locate your margin for a restoring dentist. In order to locate your margin and make it a healthy situations, the sulcus shouldn't bleed. If it bleeds, you cannot capture a real margin. So in this case, to put a team in one case, it takes a courage and difficulties. It was hard to communicate with the others because some of them, they don't like accept or they don't want to treat the case as complex cases. So I took my courage to collect the data of the patient. I was the team leader. I called an endodontics, prosthodontics to manage the caries control, the placement of the temporaries, bite raising, crown for the implant, and crowns for the aesthetics. The ortho also need to close the spaces and change some intrusion of the teeth. The parental treatment will include some disease control of gingivitis, ridge augmentation, and implant placement. So it's like multidisciplinary. This is a case that it fit the topic of the multidisciplinary approach. As you can see, when they started the root canal treatment, they started with the posterior teeth and the anterior teeth. Appreciate how much work the endodontics put on to control the apical lesions in this case. Most of the teeth in the upper receives an RCTs. Likewise, posterior mandible, we did some extraction of the teeth, and she had treatment for the premolars. This is the final RCTs with the, you could appreciate they want to place a post and core in the area. That's why they did some post space for the restoring dentist. And I just make a comment. I think one of the best to make a post space is the endodontics because they know the canal anatomy. So as a restoring dentist, if you have communicating with some endodontics, ask them to make this post space for you. Now it's a time after disease control and extraction of the hopeless teeth, it came for the prosto to change the bite. And this is the next step after controlling the disease is to change the occlusion of the patient. They used some removable appliances. They did some RBD for the upper and for the lower. And with time, they changed the bite until they obtain the ideal vertical dimension, which is about like 2-3 millimeters, changing the bite of this patient. And you could appreciate now after disease control and eliminating some of the teeth that was unrestorable. Usually we utilize the diagnostic cast to have wax up to show the patient what will be the size of the teeth and their shape. Now it's just the periodontist to go for the crown lengthening. We started the crown lengthening of the upper jaw, then placing an implant to implant in the premolar area. And it was extensive crown lengthening with bone removal because there was a vertical collapse, the clinical crown was short, so we have to remove some bone in order to re-establish biological width. And this is the message for the restoring dentist. Please, if your patient has a previous restoration, usually, or old crowns, usually they need to have re-establishing the biological width because this is the recurrent caries, vicus margins, they have to have usually crown lengthening procedures to be done before doing the final restorations. So this is the case, close up after crown lengthening. You could appreciate we need at least from the margin to the crystal bone at least 3 millimeters. This is the case after healing. We installed 2 temporary crowns on each side for the implant, and the orthodontist will use this temporary crowns to pull the teeth out to close the spaces from the canine to the canine, because we thought if you just close by the veneers, she will have like a huge teeth. So the orthodontist suggested to have a space closure in order to obtain a good size of the teeth in this case. So this is the case after installing the implant on the right side. So we placed 2 implants. Unfortunately, We placed it without augmentation. That's why you could see the implant a little bit lingually placed. So we learn from the mistakes. In the right side, we tended to place blood grafting, and I will show you later that side. So this is the case after crown lengthening and the initial healing. You could appreciate how much effort was put in the case in order to, this is the start of the case. And this is like 6 months later after putting the implant and temporary crowns. So the orthodontist will start to close the gap in the canine areas. So the patient now, she starts to realize dentistry has changed my life. This is, you could appreciate, even with the temporaries, the patient started to take care of the teeth. She started to come for the appointment, and she, instead of like neglecting at the beginning, and she does want to have an implant for the whole teeth, now she's saying, no, I want to keep my teeth. This is the look, I want to keep them. I don't want to extract them. So the author started to close the space between the canines and the laterals in order to minimize the size of this canine later on, not to have like a huge teeth with veneers or crowns. Also, we did some change in the vertical dimensions by pushing the teeth a little bit apically. Now it was the time for bone grafting as a black bone at the lower right mandible. Why is that? Because the extraction was done before she came to the clinic, and we could see the ridge collapse after. There's a huge defect in the premolar and the molar area. And literally, this was the first case I did the blood grafts at that time, 2005. So I did it like with the traditional technique using from the external oblique ridge, and this was my first case to do the blood grafts at that time. I used like regular diamond burr and surgical, but you could see how much bone destruction that you could do with the straight hand piece. So the new technology has changed our life in bone harvesting by using the piezo or the saw technique for Khoury technique. This is like an tremendous change for bone augmentations by the blood grafting. So we obtain about 15 millimeter of the bone grafting from the same side. Then we place the two blocks directly contacting the recipient side without any gap. So this was the case. Now, later on, 5 years later, when I start to learn the Khoury technique, I changed my technique to the plate technique, not to the whole block technique. I used one screw to fix the blocks. I added some particulate from autogenous with the allograft bone gel in that area, and I noticed I covered only one area with the membrane, and I lifted the other side without any membrane to protect the bone grafting. Complete closure, primary closure, of course, with the bone augmentation, you have to have a complete seal to avoid any infections. Then patient came in 6 months later for the implant placement. You could appreciate the amount of bone that we gain and amount of keratinized tissue in presence. And I noticed the side that we didn't cover with the membrane, there's some bone loss. So from this case, I learned, I think, in order to have a success in the GBR or the bone augmentations, doing a GBR around the block and doing membrane, it gives like a privilege to protect your bone from resorption, and that was noted in this case, as you could appreciate. In the premolar, with the membrane, no bone defect or no bone loss, and this is we have like about 3 millimeter or 2 millimeter bone loss around the screw head. So after the implant placement, the orthodontist start to move the teeth, and you could appreciate the screws with the bone fixations in that area. And this is the change that we noticed. You could see the bony defect in this area and huge bone gain with the block augmentation. Although it was an old technique, as we said, but we applied the concept, intimate contact. There is decortication of the area and perforation. So it was a plus to have like complete and huge bone growth in that defected area. And pay attention when you do the implant. Don't jeopardize your keratinized tissue, please. If you don't have it, create it. If you have it, maintain it. I noticed some dentists, they go just to do the, like punch technique or drilling technique without reflections. No, keep your keratinized tissue. If it's there, if not, you have to create it around your implant, because it maintain or to give you a long-term success, as you're gonna see later. So this is the case after cementation of the crowns of the blocked area. You could appreciate the amount of bone that we gain and the nice contour of the ridge on that side. And this is the case after correction of the occlusion with the ortho and with the raising the bite. You could remember the case was collapsed. Now, after correction of the bite, now we could have a nice occlusion for the case. This is the case 1 year later with the full ceramic crowns constructed. And it could appreciate the area that we did bone grafting in the lower left side, nice contour of the ridge, and we have slightly defected area that was not augmented prior to the implant placement, although it looks nice, the patient happy, has no complaint. But for us as a periodontist, I think we need to have like a nice contour of the ridge just for comfort zone, although the patient has no complaint with that area. Now, she said, that was amazing job. Really, my teeth is still there. She changed her life. That was almost like 1 year later from the start of the case. She said, from the beginning, she said, I want to have an implant, and all my teeth now, no, I want to maintain them. So the patient, after finishing the case, she was in maintenance recall twice a year. She will come to the clinic, she will visit the hygienist. I will see her on a yearly basis to check on her if there is any defected restorations or any carious lesion or any parental disease that has developed or any bone loss around the implant. So the key of success for the case is also maintenance, not only the treatment. I didn't show many techniques because I'm just focusing on the maintenance care and how to communicate with the other, from where to start. This is the case after full mouth establishment of the bite and changing the occlusion and closing the spaces and alignment of the teeth, implant in place. A year later, everything was in function. You could appreciate the crystal bone around, this is still remodeling around the blood grafted area. 1 year later. This is 3 years later of the case. The blood grafted area, you could appreciate the amount of keratinized tissue around this implant, the premolar and the molar area. Just she has a loose crown, and I took photo to see how much bone or soft tissue around this implant. You could appreciate having keratinized tissue give you a nice emergency profile and give you also optimal health around your restorations. This is the full closure of the case 3 years later. Patient, you could appreciate the patient how much care she's taking care of, because as a dentist, we changed her life. We played with the psychology, not only just mechanical treatment, but also psychological impact to the patient. This is 2011. Patients, as I said, coming twice a year for hygiene and follow-up appointments to check for the implant and crystal bone stability. You could appreciate the amount of remineralization around this implant that was blood grafted area. This is just to compare 2006, 2008, 2010, and 13 bone, and there is no sign of any infections or any bone loss. And I think that one of the key factor in this case, also dealing with the bruxism, as we said in the problem list, we gave the patient the night guard to protect the occlusion and to protect the implant, not to have any bone loss because of the bruxism. As we know, one of the reasons of bone loss around the implant is heavy occlusion. This is the closer view of the whole mouth with the OBG. You could just, I was thrilled to reach to this case after this years from 2005 to 13, like almost like 8 years later, things are stable because the maintenance occlusion was protected, communication with the dentist, who is restoring the case, who is doing the root canal treatment, who is taking care of the hygiene, which is like follow up the case. I think all of them, they did a great job to maintain this case. I just close a few to the crystal bone stability around this implant, in the upper right side and the lower right side, then also in the upper right side and also in the lower left side, the right side of the blood grafted area. 18, the case is still there, no change, and the bite of the patient. She's still maintaining the whole teeth, almost like, let's see, how many years? 13 years later. I was like thrilled. I think the happiness of dentist is to reach to this point when you see your success years after years, not only, as I said, just to take the photo for the snapshot and show the before and after. No, maintenance of your restoration, if your work that you have done is the key of success. Unfortunately, in 2018, she started to lose that single crown, which is the upper left central incisor. So we decided to have an implant. This one, the crown is failing, so we decided to have this tooth out. So it's extracted. That was the only tooth she lost from that period of time. So was extraction atraumatically, and it was pulled off the socket without any forcing to the bone. An immediate implant was placed with some soft tissue augmentation to the buccal bone, to the buccal tissue to give us thickness and emergence profile. Then immediately loading the tooth with the same crown that she came on, that was failing crown. And see, we use it as a temporary. So we realign it, then we cement it back to the loading abutment. But we took it out of occlusion, almost like 2 millimeter out of occlusions, with minimal suturing, minimal trauma. There was no much flap reflections, only minor flap reflections, with bone augmentation around the implant and soft tissue to the labial aspect in order to give us emergence profile to this case. This is 2 weeks later after suture removal. You could appreciate the tissue still contouring itself. And this is the day of the cementation of the crown. See the blanching of the tissue. And this is 6 months later with the nice papilla regrowth in the interproximal area. Luckily, I saw the patient still 2 years later. As I said, we follow up the case. I never just ignore them. So this is 2 years later after the implant in the upper central incisor, and you could appreciate the amount of tissue that we gain. Even it was like we lost some papilla at the beginning, but you could appreciate the amount of aesthetics that she had. This is 15 years later from we started, with all these badly decayed teeth, infraocclusion, super eruption of the teeth, a lot of preapical lesions, and still we have stability of the bone around these implants. There is no sign of any preapical infections. There is no sign of any crystal bone loss around this implant. And I love this, just to draw this case, as you can see, the bone stability around the interproximal bone that as we see in the x-rays. And this is like last week picture of x-rays for the implant, and so almost like 2.5 years for the central incisor that was replaced with the implant. Extra year later, everything is stable, maintained, patient is happy, the dentist is happy, and my hygienist, she's like, I think she's doing a great job to maintain the case and look up. Usually, I think one of the success to mention is to train a dental hygiene how to look for the any sign of infection, because as a dentist you are too busy to see your cases. If you train 1 or 2 hygienists, I think it is one of the key of success in your practice. A smile. 16 years later. So just to conclude my presentations, certain periodontal procedures are designed to provide for adequate tooth or teeth length for retention, like crown lengthening, access for tooth preparation, impression making, and finishing of restorations. Failure to complete these procedures before restorative care can add to the complexity. So if you don't pay attention to your dental health before starting the procedure, you could have some complications down the road. What are the benefits of multidisciplinary approach? Improved patient care and outcomes through development of an agreed planning. So planning in this case, from multidisciplinary, multi-views, from the endodontics, from the restoring dentist, from the periodontist, from the hygienist also, she was involved. It is like a thrilling for us to, we educate each other. Each dentist or each specialty, he will educate the others what they are looking for. Education opportunities, improve coordination of the care of cases, streamline treatment pathways. So when you have a flow chart or a flow for the case, it will be just easy for them to communicate with each other. The benefit for the patient, she or he will get the most appropriate treatment decision made by team approach, improve satisfaction and care of that case. As said by Dawson, to have an accurate starting point, every problem to long-term health must be recognized. Planning the complete process to visualized endpoint should come first. So you should see the case, how it will end before starting. This is the key of success. Thank you for your invitations. Thank you.
Thank you so much, Khalid. I have to say, I truly enjoyed it because you brought a very, very important aspect in our practice in this presentation to all of us. And that was really the multidisciplinary approach. And, you know, there's a question I always ask during the hot seat season 3 for all the guests. And that's, the question is this: do you think that many practitioners are doing over treatments for the patients? And I think with the thing that you showed us, it's really the answer, I think, going to be yes in many cases, because sometimes we really can save teeth and do simple procedures and bring the smile back to the patients. But so many practitioners decide to extract all teeth and make their job easier or maybe faster in one day or something. So I think we really need to think comprehensively about our patients and think that if that patient is our relatives, so, and how can we manage it, and how is the patient demand? Do you agree with me in that comment or no?
I totally agree. Yes, I totally agree with you, because I have seen a lot of cases in the Instagram, the social medias. They just happy with doing like full mouth reconstruction by implants,
Yeah.
or sometimes mild decrowding. They will do just veneer preparations to have like a white smile. But you could do a lot with simple technology of dentistry, as we saw in this case, by thinking out of the box,
Yeah.
by involving the patient in the treatment, by communicating with others to bring. I think as a dentist, our aim is to save teeth at the beginning. It should come first, not extracting them. We extract teeth not because we want to extract them, no, because they are hopeless. We cannot maintain them. A lot of cases to be maintained, yes, of course. And I shared a lot of my cases in the Instagram that even that hopeless teeth with dental teeth, it could be maintained for long period of time. If you know the key of practice, if you know the biology, the biomechanics, if you involved out of discipline, you could maintain a lot of teeth. Not just by pulling them and putting like full mouth reconstruction implant. I think most of dentists, we could do that. Just take teeth out, take an impression into the lab, do full mouth reconstruction. It's an easy job, not any more difficult.
I think
but maintaining teeth is the key.
Exactly. If we explain the planning and about how it will end in future, I think most of the patients have that demand and have that acceptance when we explain to them. But maybe sometimes the problem is from our side, that we don't put enough time for our patients to explain what are the options and how they can proceed. Because patient is one hand and we are on the other hand, so we should have a balance. And you really showed beautiful case, because everything was there. And you know, the most important aspect, I think, of your presentation was 15 to 16 years of follow-up. because, you know, in 6 months, some people think that, okay, it works in 6 months, it works in 1 year, 3 years, but 15, 16 years of follow-up is, you know, it shows that it works. And that was great. You know, I have a question, uh, especially in the posterior segment, especially in the clinical photography, not in the panoramic view, we had a lot of supra-eruption of the teeth and there was no space. So if I got it right, you corrected the, occlusal crown space with the removable prosthesis, right?
Yes. Usually what is the steps will be involved? First, you will give the patient the denture without any change of the bite. So they will take it about for 2 weeks just to get used to it. Then maybe you will increase the bite 0.5 millimeter or 1 millimeter for 2-3 weeks in order to train the TMJ not to have any problem. Then incrementally about another 0.5 millimeter for the next 2-3 weeks. So it will take about 4 to 6 months until you get the stable occlusion. So in order to train the TMJ not to raise it one time, maybe 0.5 millimeters, then 2-3 weeks later, 0.5 millimeters, until you train the patient TMJ for the new bite.
Yeah, and do you?
It's a good question because some of them they will go directly. Yeah, some of them they will go directly to raise the bite. No, take it incrementally.
Yeah, and do you add to the removable only in the lower jaw or in the both jaw?
Yeah, you could. Whatever you choose, one of them you could utilize.
Only
either
one.
in the upper or in the lower. So usually I prefer to do it in the upper. Yes.
You prefer to do it in the upper?
Yeah.
Yeah, good. Because, you know, I think so many dentists will face such problems that they don't have enough occlusal crown height space for the patient. And, you know, I think the idea of using removable, not only we give the patient biting opportunity during that time, but also we are using that removable prosthesis to increase the space and make our job easier in the future. So that was a really great point. And I noticed that I think the tooth number 8 also will have a caries in the future, the one adjacent to the implant. So my question regarding that, because I saw
you're right.
underneath the crown, so that was just my thought from the radiography. So my question is this: in such cases that you follow the patient and you see that the patient cares about him or herself and come to your office regularly for the hygienic procedures and etc. Sometimes as a dentist, we see that we have little caries underneath the crowns. And we know that maybe in the future that crown fails. So I want to know, which category are you in?
Yes.
Do you prefer, if the hygiene of the patient is good, do you prefer to follow the patient and when the crown is lost, then you go for the second approach? Or you prefer to immediately tell the patient that, okay, I see some type of caries there, it's good to remove the crown, and you go with the immediate approach to solve the problem? Do you put the patient on follow-up if the hygiene of the patient is good, even when you see caries under the crown or not?
Usually, if the patient's hygiene is good, I put them in six-month recall. But if I see them like with such cases with full mouth reconstruction, if they are like radical oral hygiene, I'll keep them 3-month recall, a shorter period of time. So in this case, because she was well motivated after, like, we changed her from 2005, 2006, 1 year later, after all this work, she started, her mind changed. So we put her in 6-month recall. At the beginning, it was like a 3-4 month recall, but now we noticed that her motivation was higher. So we put her in 6-month recall. So if like she developed like maybe 13 years later, the recurrent caries has happened. And I'll tell the patient, there's some decay. If you will take care of it with the flossing, with the water flosser or with the super floss, it could slow down the caries. And I'll keep your crown in place. Once you have a problem, like tooth start to move, this is the time to, or the crown start to move because of the decay, we'll take it out. I will not interfere unless there is periapical lesion, because periapical lesion will destroy the bone.
Exactly.
But if you are still in the crown era, I'll keep it until it's down by itself.
Exactly. I'm totally agree with you, because I've seen... Yeah, go ahead.
If it is with the, as we said, if it is related to the periapical area, bone related, no, I will interfere. If it's only to the dentine or to the root area, I'll just keep it in place.
Yeah,
I agree with you totally.
I totally agree with you because I really saw it in patients. Sometimes patients come to us and they have that crown for about 15 years. And when we examine the patient, we don't see any inflammation, we don't see any movement, we don't see nothing. And you see some kind of caries underneath the crown, but you see that the patient is good, the function is good, the hygiene is good, and no problem. And it's there for maybe 10 years, 15 years. So I usually put the patient on follow-up, and really it works. So that was good to hear that from you too, because everywhere in the world, I think it happens the same. And I think that was really interesting. So, I think there are a lot to talk about on your case and cases similars. And you mentioned many good points, especially in the discussion part, that you said that so many dentists can do aesthetics, so many can want to just rush in the treatments and do everything fast. But the concept of the slow dentistry and how you can explain to the patients the parameters that are matter to the treatment outcome, and how we can go step by step to rebuild everything. Instead of eliminating every problems by extracting the teeth. And you showed beautiful follow-ups, and that means a lot, I think, for all of us, and at least is a reminder that when we examine the patients, to think twice and go with the right protocols, not what patients want and not what we all want. What is good for both sides in the treatment. Khalid, I have to say, I want to thank you so much for this great presentation. I think everything was so clear for all of us, and the point of multidisciplinary meant a lot to bring it during this presentation. And really want to thank you so much for your time and for joining me, and really hope that this pandemic ends soon and I see you in person anywhere in the world. Thank you.
Thank you so much. Thank you. Really, it was a pleasure to be around, and I love your show. Thank you for having this show. It is highly, anybody want to learn from all the things that you presented. It's a great show to watch. Thank you so much.
Thank you so much. Take care and stay safe. Hope to see you soon.
Have a good day. Thank you.
Have a great day.